TopMedTalk.
Welcome to TopMedTalk. We are here in Chicago at the Society of Cardiovascular Anesthesiology's 41st annual meeting. I'm Desiree Chappell, host and managing editor of TopMedTalk, and I'm joined by one of my partners now, Sol Aronson. I'm calling you my partner, Sol.
Now. Good to see you, Desiree.
Good to see you, Sol. Thank you for sitting down with us and hanging here. This is your space.
This is my space.
Yeah, the SCA. You've been around with them for a while, haven't you?
Too many years.
Oh, that's not true.
Too many years.
That's not true. You've been a force, I think, in this organization. So lots of thank yous from a lot of people.
And we are very honored today.
Yep.
To have Robert and Shanari. What a lovely name.
Thank
I love
you
that.
so much.
From Temple. Both of you are residents
Yes, sir.
at Temple. Which years?
I'm a CA2.
And
I'm a CA1.
First question, I got to get it out of the way. Genos or Pats?
Pats.
Neither.
Oh, where do you want to go with this?
D'Alessandro's is by far the best.
Nice.
Okay, I'm going to assume that's pizza, right?
Cheesesteaks.
Oh, cheese. Oh,
Philly Temple
Come on.
cheesesteaks.
my God, I don't get out enough, apparently. Oh, my God, that's hilarious.
Okay, now that we got that out of the way.
Oh, my God, that's so funny. Okay, so now that we know your preference for cheesesteaks, I know that you guys both have posters here this year, so I would love to hear a little bit more about what you guys are presenting. So, Shanari, would you
Sure. So my poster is entitled Cardiac Tamponade in Acute Type A Aortic Dissection. And it was interesting, a case that we had, and I thought it would be lovely to present here because, one, these two pathologies don't very frequently occur together. Two, when they do, the patients unfortunately often meet their demise before they make it to the operating room. And three, in the case that we realized that the blood in the pericardial space was clotted, which is also quite unusual. So I can tell you a little bit more about it.
Yeah, I do.
Please, yes.
Yeah.
Yeah.
Sure. It was a male in his 50s who had poorly controlled chronic diseases of hypertension, diabetes, and hyperlipidemia, as is the case with many of our patients. And he was going about his regular day, and then he had sudden onset of chest pain, shortness of breath. After about 12 hours of it worsening, he presented to our emergency department, and it was found that he had an acute aortic dissection. This was diagnosed on CAT scan after clinical evaluation prompted them to get this study. And so at this point is when we became involved from anesthesia, and he was brought emergently to the OR. Typical for this case is that we do ketamine induction, and we attempt to preserve spontaneous ventilation and that negative intrathoracic pressure that will help drive preload and help counteract the obstructive shock that the pericardial tamponade is essentially creating. And just prior to that, what we did for this patient, because he was quite hemodynamically unstable, is that the surgeons attempted a temporizing pericardiocentesis. And unusually in this case, it was unsuccessful with a negative aspiration. So we proceeded with our induction with just a very small dose of ketamine to facilitate video laryngoscopic intubation. And we did that successful on the first attempt. Thankfully, he didn't have any further hemodynamic compromise because he was already in multifactorial shock. And prior to us even inducing anesthesia, the patient was prepped and draped, and the surgeons were ready for incision. So that quickly took place after the induction, and they opened the pericardial space and found that there was a large amount of clotted blood. We did anticipate, too, in this case, that the patient might have severe rebound hypertension because he was already on vasopressor support, and with the relief of the obstruction and the massive release of these agents into his systemic circulation, we thought that this could occur and cause secondary injury from a new hypertensive emergency, which could be potentially fatal and lead to rupture or further sharing of his aorta. So we anticipated that. We had nitroglycerin, for which he required only small doses, and thankfully the case proceeded well. One of our concerns was that we weren't sure, because of the limited amount of studies before, we didn't have time to place a TE. They did not do, he didn't have a TTE in the ED, and we were concerned about how contained this this effusion was. And sometimes, too, because in the event that there's a very contained rupture, and when you do create a pericardial window, then that could actually cause catastrophic large rupture of the aorta. Thankfully, that didn't occur in his case, and after this quite eventful start to the case, it proceeded pretty uneventfully. He went on cardiopulmonary bypass. He had deep hypothermic circulatory arrest. The rest of the case proceeded uneventfully, but it was just a very interesting learning point, especially since I'm very earlier in my career as a CA1. I thought it was interesting to remember the importance of maintaining spontaneous ventilation throughout the period of induction, anticipating potentially dangerous rebound hypertension, and managing the patient appropriately, and very importantly, having good communication with the surgeon. So they attempted the pericardiocentesis, it didn't work out. We had to go for Plan B, and we have to be thinking quickly and on our feet.
Wow, that's
great pace. And how lucky for you as a CA1 to have that chance. Were you on call?
I was on call.
Okay. Those are the kind of, really special moments just because of the nature of the physiology. Takeaways, you mentioned importance of spontaneous ventilation. Did you do any perturbations during your induction to see if he could tolerate positive pressure? Did you have him breath hold? Did you try to sneak in a positive pressure? Did you try to give yourself an opportunity to see what his tolerance to that perturbation was?
No, actually.
Darn it.
That would have been a cool
No,
one,
we
too.
didn't.
Yeah.
We just thought this would be the safest thing, and with limited time, we didn't have really much.
And help me. So you didn't do a intraoperative or pre-induction echo, albeit transthoracic or TE, of course. So your diagnostic knowledge of the extent of the pericardial infusion was based on CT.
Yes.
Anterior, posterior, both, or undetermined?
On both the axial and coronal images, it appeared to be circumferential.
Okay.
And that's really all we got from the CT.
And did you have a sense of it being thrombotic or clotted? And pericardial centesis probably didn't work because of that.
Yes, it was. We later found out that it was because it was clotted, and we didn't have a sense of that from the CT. I think probably because of the short time frame for all of these things occurring. It hadn't been determined whether, based on the density of the fluid on CT, that it was clotted, and we really didn't anticipate that. So that was quite surprising.
He had a history about 10 to 15 years earlier. Had a right lung transplant, had an acute rejection, which was treated, and then another rejection, which was treated. And by the time he came in for his second lung transplant, his native lung was severely hypertrophied. We were able to appreciate this on imaging, CT and X-ray, preoperatively, but didn't really know exactly how that would influence our take on the case. And pretty early into the case, we started to realize we were having issues. Placing a double lumen tube was particularly difficult. We actually had to do it over a fiber optic scope, which we do not usually do. And then we were able to secure it and get bronchial isolation on both the right and left lungs. And then with the going through the case, we also had trouble placing the swan gans. We tried to use the TEE. However, the heart and the trachea had about 5 to 6 centimeters of deviation, so you really couldn't see very much at all with the TEE probes. We were kind of blind with that. And then once the native lung was explanted, we started having issues again with the double lumen tube because everything started to switch just a little bit back and enough to cause us to actually hold and pull traction on the tube for a considerable amount of time to actually get a seal. However, our swan gans was finally accurate, and our echo probe is finally somewhat accurate. So it's not nearly as exciting, but a couple learning points that I will take with me going forward.
Which are?
Just the consideration of that, how I think I would probably start with a fiber optic intubation in these patients. I would be aware of the fact that I'm probably not going to have swan gans assistance or echo assistance until native lung is explanted. and just really being prepared for that. It was a little challenging going into a double lung as an early CA2 or single lung, and having surprises like that fall upon your lap.
And anticipated off bypass single lung, I'm guessing as well. Yes.
Correct.
Okay. And where in the case were you wondering why it was you instead of Sharuri that was having to
That's hilarious. That is one of those cases.
Why me? Both great cases. Do you think you're going to change your practice going forward to more rapidly go to a prophylactic or intended fiber optic guided double lumen tube placement?
I think I might, especially in a case like that where there's such significant tracheal deviation and such significant native lung hypertrophy. You do get worried about the double lumen tubes are pretty darn stiff.
Right.
And they're not intended for 6 centimeter deviation or 5 centimeter deviation. I'd be really nervous about causing injury. And throughout the case we were. Fortunately, we did not, but I think if I just kept blindly sticking a double lumen tube down that type of trachea, it may cause issues. Yeah. So going forward, I absolutely think I would treat that differently.
Great teaching moment. So other teaching moments, both of you, great cases. And can I just say, great to have you describe those great cases to us with such a equipoise and sense of maturity. Boy, am I happy that the future is in good hands, talking to people like yourselves. Your CA2, CA1, future in cardiac anesthesiology, or too soon to predict?
For me, so I came into residency being very interested in cardiac anesthesiology. I still am very interested. I'm also very interested in pain management. So I like both. We were actually just speaking to someone who did both fellowships, and I was encouraged when I came, and I see that how much pain is becoming integrated into the practice of both major and minor cardiac procedures. I looked at quite a few of the posters here that were interesting, and some of the exhibits too, and the use of erector spinae blocks, the use of paravertebral blocks for SICD placement, the use of, and then there was one case too of both of erector spinae blocks for aortic procedures, and I just think both fields of subspecialty study are so different, but so interconnected. And I think as more and more as we're moving toward regional anesthesia, especially in patients who are with complex cardiac problems, I think that there's so much usefulness, especially as we go forward. And I really like both of them, so I may do both. All right.
And tell me where you're from. This is your time to shout out to whoever's listening. Give us a little bit of your background, if you will.
I am from Trinidad and Tobago, which is the southernmost Caribbean island and country. Trinidad being just even more south than Tobago, and it's very near to Venezuela. And I recently came I'm at Temple. I recently came here for residency studies. So the weather is very different. And I went to medical school back in the Caribbean. And then I
asked where you went to medical school.
And then I recently migrated here.
Wonderful. And Robert?
Yes, sir. I am definitely going to cardiac anesthesia. Match day is under a month away. I cannot wait to find out.
All right, Shariri, did you hear that? That was the correct answer. Pay attention.
I love her.
Yes, I'm hoping to convince her to go into cardiac anesthesia. She's one of our star residents. But yeah, definitely going to cardiac anesthesia. I absolutely love it. Anxiously awaiting the next 4 weeks or so.
And where are you from?
I am from Pennsylvania. I moved around quite a bit growing up. I went to medical school at Temple, and then had a little bit of a break between medical school and residency. I was in the military for 5 years and just restarted residency 2 years ago.
Wow, what a inspirational
I know,
group.
Both sides.
Yeah.
Thank you for your service, by the way.
Yeah.
Thank you.
Wonderful.
Desiree, question, education. What you guys represent a generation that is different than mine.
Yours and mine.
Teach us how you like to be educated.
Yeah. Like what is resonating with you now? I mean, I know that you probably have mentors and, your professors' age ranges are very different and teach in very different ways. What is working with you guys? Like what feels good and you get the most from those experiences? Sherry?
To begin with, I'm extremely grateful for the opportunity to be here at this conference. And I think that as residents, like in our generation, when I talk to my attendings, like they weren't as exposed to conferences and to what's new in the specialty until they were later on in their careers. And I think that we learn both by integrating our clinical experience with didactics, and the didactics here are different to textbook-based didactics, which we are traditionally exposed to in residency. So I think that this is an important part of our learning experience. All of the lectures so far have been really, really great, and with especially because at our institution we do so much cardiovascular anesthesia, and we're actually the number one for 2 years in a row, the number one lung center in the nation. Like we do so much, and coming here and seeing how many ways there are to achieve a common purpose is really, really a wonderful experience, because I feel like even as a CA1 that there's so much that we have to learn, and I believe that talking to other people and gaining other people's perspectives, even my fellow CA1 colleagues who I've met throughout presenting my work here, it's really valuable to take back and to see how we could implement some of the things that are done at other institutions and see how they work at our institution, even just anecdotally, and then probably even further go on to study their benefits.
Yeah, that's cool. Robert, what do you think?
I'm a little old school in this mentality, which may not be what you're going for, but
it's important to reach everybody.
Absolutely. I'm a firm believer in mentorship and leadership. I think I've been very, very, very fortunate throughout my career to have some phenomenal mentors that you can really see. They show you how to act in the operating room as well as beyond. I think I've been.
This is your chance to salute them. Anybody we should know about?
Absolutely. I guess I'll start with I think our chair is one of the most inspiring people I've been blessed to be around. I think he inspires you to be a better person and the best anesthesiologist you can be. We have quite a few, and it's Dr. Gordon Morwood. Our program director is incredibly dedicated. I've never had a more fierce advocate than her. Many, many, many of our attendings in Temple, and then in the military as well. They show you that what you do reflects upon yourself and the institution, and that should mean something. They really lead by example, and I think that's so important. You get a lot of attendings in other spots where they don't. They see we need to do our job and do it right, but that's kind of it. I think it's an opportunity to influence generations if you do it right. And the few folks that really do that right, I mean, I feel my life's been changed by them. And that's what I hope that we take forward, is that we're able to do that for the subsequent generations. And I think it's really important. Something gets lost.
Well, there must be something in the water in Philadelphia. Or must be Geno's or D'Alessandro's, because obviously something really good is coming out of Temple and Philadelphia, and it's reflected by both of you. What a pleasure to speak to both of you.
Thank you so much.
Thank you guys so much. We look forward to hoping to catch up with you maybe in the future.
Sure.
Yeah.
Thanks so much for the opportunity.
Thank you. Maybe we'll see you here if you both become cardiac anesthesiologists.
Yes.
Cheers. All right.
Good.
Well, thanks for listening,
Sure.
and we'll catch up with you next time.
Okay.
Cheers.
Bye.
Cheers.
TopMedTalk. Nick Majerison here. Thanks for listening to TopMedTalk. Now, before we let you go, it's important that we remind you to subscribe to TopMedTalk. That way you'll never, ever miss another episode. Also, if we could encourage you to join us on social media, Twitter, Facebook, LinkedIn, YouTube, pretty much every single social media platform, we're there. Join us. And finally, check out TopMedTalk.com. If you go to our website, you can subscribe to email updates. That way we can always tell you where we're going to be, what we're going to be doing, and how you can join us. TopMedTalk.com and click on the section marked email updates. Finally, TopMedTalk is proud to act as the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about them as well. ebpom.org is their website. That's ebpom.org. And if you go to ebpom.org/meetings, you can find out about some of the wonderful meetings that we attend and cover across the year here on TopMedTalk. That's ebpom.org/meetings.